Good evening, everyone. Thank you so much for giving us your time today. My name is Menna Haider. I'm a medical oncologist focused on neuroendocrine tumors at Moffitt Cancer Center in Tampa, Florida. And I am joined by two wonderful panelists who are friends and colleagues, and I'll introduce both of them shortly. Our topic today is a review of the outcomes and important discussions from our national annual symposium at NANETS. NANETS is the North American Neuroendocrine Tumor Society, first founded in 2006, totally dedicated to the academic progress and education of neuroendocrine oncology providers. And since then, it has grown to over 500 members. We had over 500 attendees at our last annual symposium in November in Chicago, where we got to see some snow as well. And a lot of important discussions were had, including new data, new outcomes from clinical trials and updates. And over time, NANETS has really focused on partnering with our community in terms of advocacy and making sure that the information that we're sharing in terms of provider education is shared with our patients, their caregivers, and also within the medical community, so it's not so siloed within specialty centers, and you can receive care within the standard and within guidelines. So today I'm joined by Lisa Yan, who is not new to our community here. I want to thank her for always being so supportive and available. You were here at our first in-person meeting, providing guidance and support, and it's so good to have you here. She is a nurse practitioner who brings her experience as the Director of Outreach for Learn, Advocate, and Connect and Neuroendocrine Tumor Society. Lisa, I'd like you to start by introducing yourself again to our community.
Thank you so much, Dr. Haider and the FLaNET team for having me. I remember actually way back when I was with Dr. Strasberg in Europe at a conference, and he was telling me about the launch of this support community and how exciting this is that now you have this. So again, as Dr. Haider said, my name is Lisa Yan. I live in California, in Los Angeles, California. We are safe from the fires and things are going much better. And my background, as Dr. Haider said, is as a nurse practitioner in hospital medicine. So I was on the other side of things, taking care of people, not in oncology, but people who were admitted to the hospital until January 2nd, 2015, when my husband was very suddenly and unexpectedly diagnosed with advanced metastatic pancreatic neuroendocrine tumor that had spread already to the liver and later to the bones. And that, as many of you can understand, upended my life, completely changed courses. And through the journey, what was our local patient advocacy group at that time, FLaNET, helped guide us and help provide support and education. And then I was invited to join staff in 2018. So FLaNET used to be a local regional support group in Los Angeles. It was founded in 2012 by a patient called Giovanna Joyce Mbesi, who was amazing and a visionary. She was a musician and lived and thrived with neuroendocrine cancer for 14 years. And she was the one who founded this. It was actually founded at Cedars-Sinai along with Dr. Edward Wolin. And she invited me to join, and our team has grown. And with COVID, we definitely grew and changed and had more of a national reach. So we rebranded a few years ago. And that's why the name Learn, Advocate, Connect to reflect that larger reach. So yeah, thank you again for having me. It's an honor to be here.
Thank you so much. And so can you, I get to see you every year at the NANETS meeting, and we are trying in FLaNET to also bring NANETS closer and translate the learning that we do there. Can you explain the role of a patient advocacy group and how that has grown within NANETS so that we can also look at goals for the future?
Yeah, now that's such a good question. We used to be, as you said, more siloed, right? The NANETS is providing education for providers, and really that's their mission. And patient advocacy organizations are really providing education and support for patients and caregivers and the patient community. So they're two separate and distinct entities, and yet there's a lot of information that's shared. And so we started meeting 3 or 4 years ago as a committee to try to bridge the gaps and work together, identifying and bridging those gaps. It's helpful to have all parties at the table to name it, to say, hey, these are the things that we notice and what can we do about it? And that's been moving forward. Some of the ways that we've been doing things is, well, a lot of it's based on relationships like this, where we're talking and then um, we're providing our insights and feedback. And then from there, we're like, hey, we can do something about it. Let's do something about it. And sometimes that's organic, and sometimes it's a project that is formed by the committee. I know for LACNETS, we've heard from patients many times. I'd love to be a fly on the wall, or even a lot of patients who want to attend some of these conferences. And from attending the conferences, I can say, even as a nurse practitioner, some of this is very high level and very, very scientific, and it can be very hard to understand. So we're trying to translate this and distill it down and curate this to what is important to the patient community, and how do we explain this in a way that makes sense and that matters to patients. So, for example, one thing that we've done on our own is recapping every year with a podcast episode with one of the providers. So one of the net experts, actually, Dr. Will Pena, has done this, and we're about to release our third podcast, annual podcast about this, where he takes the top 10 highlights that he sees. And I know that we've had other projects that are in development now between us and the FLaNET's team about how can we translate this again in a meaningful way. Many people do often reach out and they will ask us, "Hey, I saw this article, or I heard about this trial. What does it mean?" It's the
Mhm.
what does it mean that we're trying
Mhm.
to bridge the gap.
And we want to ensure that we tag that podcast through our website and social media, because I think it's really impactful. I think he picks the 10 most important outcomes from the annual meeting and explains it. And I actually find it very useful even when I'm doing teaching for our residency and fellowship. So it's a really wonderful podcast, and I highly encourage you to look out for that. So I think we both see our advocacy groups and patient groups as bridges between this meeting that's dedicated to providers, but bringing that information into our community. And we are looking at projects, for example, about using things that are at our fingertips, like AI, for example,
Mhm.
or brochures about even the poster presentations that are very early information, but that might drive future directions, so that we really provide our patients and our community with the latest updates, because then your feedback is important about what your thoughts are about those directions.
Mhm.
So thank you for sharing that.
Yeah, there are many opportunities for collaboration and building the community. And I just want to share with the community that there's a lot going on behind the scenes that you may not be aware of. A lot of conversations and a lot of different projects, and all of this is to benefit all of us, right? So that we can get um, accurate information out there that will mean something. And so it hopefully will ease your burden and stress and anxiety of it all being on your plate. So there's a lot of people who want to help with that. And part of it is translating it, because for how for for necessity's sake, how things
Mhm.
are communicated to providers and scientists is different. It's a different
Mhm.
language in how it's communicated to patients and caregivers.
Right. And I also want to highlight the work that our groups do for policy. For example, insurance requirements and approvals, and making sure that highly specialized treatments are not overlooked for a smaller or more rare disease with a smaller population than other cancers. Do you have any comment about that as well?
Yes, so 1 year ago, after the last NANETS symposium, NANETS launched a special committee called the NET Hack Committee. And I know we've been involved in this, where we can advocate on a larger level. So oftentimes, and I know this is true for even myself with my husband's case, we're thinking of advocacy in terms of personal advocacy. I need to advocate for myself and my loved one for our treatments or to our provider institution, insurance, et cetera. However, we're looking at globally, how can we help, or nationally at least, how can we help move things forward? How can we partner together to make an even more deep and meaningful impact? So advocating for policies and treatments that will really make a difference.
Right, and we welcome our patients and their insight and involvement in that if it's something that you would like to be involved in. So I would like to introduce our second panelist, and I think she is here now, Dr. Chandrasekharan.
Can you hear
She
me?
joined. Yes, thank you. Good evening. She is a fellow medical oncologist like myself. We've worked together on NANETS on the Continuing Education Committee, and she has recently moved from her role in Iowa to MD Anderson, where she will continue her research and clinical care focused on neuroendocrine tumors. So welcome.
Thank you. Thanks for
We were discussing the role of our patient advocacy groups as a bridge to what we're doing in NANETS, and we're going to get into some of the research that has caught our attention and we want to share. But before doing so, I also wanted to highlight our work with NANETS as well in providing outreach and net-focused education to our colleagues in the community, such that when we are co-managing or working together as a team within a neuroendocrine tumor center like both of ours with our colleagues in the community, that they also are updated, and if you can speak to the importance of that and the work being done.
Thank you. Thanks for having me here, and great to see Lisa and yourself and Tamia. Like all of us have been working together for a long time. So I think, to address a specific thing that you brought up now, Menna is now the co-chair of this committee that North American Neuroendocrine Tumor Society has now as the chair last year. So this committee was formed with the intention to improve like the education and the outreach in the community. I think one of the most common things that we hear a lot from patients, which is also a known fact in literature, is the average time from symptom to diagnosis, right? This is like one thing, especially in neuroendocrine tumors, unlike other cancers. It's a very long lag period, more than once. I'm sure a lot of patients will empathize with the situation where got this going on for years or months and like I just couldn't figure out. Nobody could figure out. And sometimes even when the diagnosis is made, and you're seeing an oncologist or a team locally, they may not have seen this as often. So even with a diagnosis, there's this unfamiliarity or of the treatments or options, or I guess the treatment nuances to this kind of difficult and rare. I don't know if I can call it rare anymore, but yes, in terms of the incidence increasing. But so this is like the two main areas, like the gap between symptom to diagnosis, like it's delay. And then even after the diagnosis, there's this gap in making treatment available or the nuances of treatment. And there's this knowledge gap. I think the first gap maybe is a lot more to do with knowledge gap in other non-oncology specialties like, gastroenterologist or primary internal medicine. I mean, I'm not saying that they don't know, but they may not have this on the radar. Like this is not the first thing on their radar, right? Like if you go into diarrhea or something, it's more common that someone has irritable bowel syndrome or like an inflammation bowel disorder. If you are a woman nearing menopause and you go with flushing, they're going to tell you you're menopausal. Like that's just statistically more common and more likely that's where they're going to be led just based on the numbers. It's not very common to have this on the list at the top. So this knowledge gap, as well as the gap, like I said, after being diagnosed, the intention is to create more awareness. I think the patient population is definitely a big part of this. A lot of the webinars that are conducted, I think we get to hear the patient perspective, which gives us feedback to go back into this education content and the outreach, like where do we target, right? So I think as simple as sometimes some patients I think have said in the webinar like, hey, I live in this particular state and we really need some more of this here. And again, thanks to the online world, we have all these online tools, but I think we also have to think about patients and doctors that don't rely on Zoom and other such webinar models, and kind of go down to their community to in person or physically. And I think so. So I think NANETS specifically, the organization officially has been engaged, and also now in sometimes partnership with patient organizations, partner like with Lisa, for example, to both get the patients as well as the physician or the healthcare team perspective. And I think this is not like a one-time same content, because sometimes, if you see some of the webinars, you may see, oh, it's the same thing being repeated, but different speakers, but the content may be same. But I think if you look at the trend over, science changes rapidly and or at the same time does not change rapidly. I think it depends on the cancer and other things. But if you look at the content from some years ago to some time recently, I'm sure there's a lot of changes that have been incorporated based on the data that's become available and also based on the feedback received from the participants. And so that's, I think, addressing both the question of what the work that NANETS does specifically on these committees, as well as how important it is to have the patient or patient organization input for that.
Mhm.
Could I
Actually,
ask- Oh,
Yep.
sorry. Could I add one thing to what you're saying? Specifically, one way that this looks, and this has been piloted and now seems to be rolling out as a regular occurrence, is that anytime that there's a NANETS regional meeting, so when they have, we're talking about the annual symposium where many people come, 500 people, but there's also these regional meetings where the outreach is to community providers. Anytime NANETS has those regional meetings for community providers, to educate community providers, NANETS is also partnering with a patient advocacy organization. So that includes us, but it also includes other organizations, NRF and NCAN and such. So they'll try to piggyback so that there are side-by-side meetings, so that the speakers who are there can also be speaking at the patient education meeting.
And I think
Right.
usually the patient sessions, I think I participated in one that Lisa had partnered with the local organization in Minneapolis, Minnesota, when I was in Iowa. And it gives the patients also an opportunity to know the community experts in their region. Not everybody can go from Florida to the West Coast or the other way or have the reach. So they get to also interface. Usually the patient physician interaction session, I think, is paired intentionally with the local expert and a national expert of some kind, so that it's very well rounded and gives patients the face time to ask general questions, not specific questions.
Absolutely. Our first FLaNET in-person meeting was joined by the Tampa Regional, and I think following that model will be really impactful. Before going on to what we've learned at the meeting, I also want to share my optimism that when I was training in fellowship, I was very lucky to be at Moffitt Cancer Center because we have a neuroendocrine tumor program. So it was part of my education to really recognize neuroendocrine tumors and learn from a leading expert. But that is not in every training program. But what is very exciting is that NANETS has helped define interest in neuroendocrine tumor oncology and is supporting young faculty who are interested in dedicating their careers and their research and clinical care to neuroendocrine tumor and the patients. And so I think our community is growing, and I'm really excited about generations of research and clinical care to come. Do we have any questions, Tamia? We can take a moment before going.
We do have one question. Can you see the
Mhm.
questions or no? Okay.
Yes,
Okay.
I see there's a question. Well, I think we can take a moment for a topic discussion, Chandrikha. So the question is, if I'm going to have a urine 5-HIA test while on a somatostatin analog, will it skew the results? And there were some discussions and some work done on a tumor marker that would be reliable for neuroendocrine tumor, because a lot of our labs can be skewed by foods or medications. What is your opinion about urine 5-HIA? In my practice, that is my go-to test, if you will, as long as I've provided list of medications and foods to avoid, to have a more reliable, but I do trend it annually. What's your say?
An interesting question, I think, also because now I practiced or started practicing in another place. And so So in Iowa, which was where I practiced, we actually did not do a lot of urine 5-HAA. We actually did a lot more of plasma serotonin. And again, every test, every biomarker that we have, unfortunately, has their pitfalls, both in terms of collection, the criteria that go up front after collection, the methodology of actually how they do the assay between different labs, different places. And then despite all of that, a false positive or a false negative rate. So like literally at every level, every step, there's a pitfall with most markers that we have at this time, unfortunately. If you look at most guidelines and most scientific societies and guidelines, the urine 5-HAA is probably the one that's recommended or endorsed. In fact, there are some recent guidelines that actually go away from chromoganin A, which is probably the most abused test and used test in this cancer. In my experience with urine 5-HAA personally, to be honest, is low just because I trained and worked in a place with a lot more where we did the straight plasma serotonin, which again has to be measured a certain specific way, which also has its problems. But we just had a process in place that made it possible. So, and because of the whole restrictions of the food things that we have to avoid before urine 5-HAA and the whole like, hey, listen, take your jug of urine test back before you bring it. Make sure you bring it and make sure you collect it. All the things that can go wrong with those things. From a simplicity sake, I think we were doing plasma serotonin at Iowa. I don't think a lot of places honestly do that. I think a lot of institutions, academic net centers still do a lot more urine 5-HAA, and I'm getting used to it at MD Anderson here. And in terms of the available test, if it's a small bowel neuroendocrine tumor, certainly that's probably one of the better ones, not the best, but the better ones available. To answer the question on skewing the results with octreotide, technically you're giving this to suppress the hormone. So definitely there is an interplay, there is a result that can be skewed. But like, let's say somebody is on a stable dose of octreotide and the levels are increasing regardless. It's again not about a single number that when we look at these tests, it's a trend that we look at. So if we have achieved a stable level and over the course of time with the same dose of lanreotide or octreotide, this number is going up, that would still worry us about something to do with this tumor, not always, but something to do with it. So I think if you think of it as a single point test, it would not make any sense. It has to be a trend. It can also make sense as a single point test. I should take it back because let's say if a patient has symptoms and syndrome and the 5-HAA is single point elevated, that kind of goes together. So there's value in that also. But to answer this question about how octreotide affects, I think it can, and the question is about the trend over time on treatment or with symptoms and what goes along with the patient.
So we do encourage you to continue your care and do your test, and that will be taken into account when interpreting the data.
It's one of the things taken into account because I think
Yes.
we worry sometimes, you just keep plotting only the number and just go by the number. Unlike other cancers, you can't, and even in other cancers, we shouldn't be treating the numbers. But in this cancer, the numbers like these are even less helpful than other cancers.
Right. We have yet to find a tumor marker that our colleagues, for example, in ovarian cancer care or breast cancer care have found quite reliable. But we are working on it.
Yeah.
So speaking of work being done, Lisa, I'll go back to you. You attended quite a bit of sessions in the symposium, and there were a lot of posters to peruse as well. So in your view, what updates or research that was shared do you think will be impacting patient care now or sometime this year that you want to share with our community?
Yeah, there was a lot of good stuff at the symposium. Of course, much of it might be early or developing research. So the question about what do you think will impact patient care now, which is what we like to think is a really key one. I think one of the most impactful ones or immediately impactful is the results of the cabinet trial. Cabinet, like, where we put our clothes, a cabinet. And that is really studying a pill that will hopefully be coming to market. The review date is April 3rd. So the whole idea that there's going to be another pill that might come to market soon is really exciting and hopeful. And this trial was a multi-center phase 3 international trial that Dr. Jennifer Chan, who's our current NANETS president, has been working on for probably about a decade. So really highlighting and honoring how much work came into this, both from research side and doctor side, and now we're able to see it come to fruition and hopefully result in a new drug. And I think the most exciting thing about this new drug, cabozantinib, or Cabometyx will be the brand name, but cabozantinib is how many different types of neuroendocrine cancer patients it can help. So there have been a lot of drugs and that are for specific types, like only GI and pancreas, or only if you have a grade 1 or 2. And really people who have lung or higher, higher grade or faster growing type of NET feel a little left out. And also a lot of drugs might be like, oh, for earlier line, like earlier in your journey. So people who've had multiple treatments, again, feel like, oh, I'm running out of options. So really having another tool in our tool belt, and regardless of type of neuroendocrine cancer, or for a wider range of neuroendocrine cancer, is really hopeful, and also showing that it works even after, or can work even after multiple lines of therapy.
Yes, thank you. I share your view. I think I'm very excited to have another medication to offer that is already studied. Cabozantinib is not new to oncology care. So the other positive is that we have clinical experience in other malignancies. And so we understand a bit more about toxicities longer term over time. And also dosing. So we have that practice history about how to dose it such that side effects are better controlled. So that historical view is there. And I do think it really is a great highlight that patients with pulmonary or lung neuroendocrine tumors were included as a diagnosis in this clinical trial. If we really look at our clinical trials in the past, we have a very small data dedicated to patients with lung neuroendocrine tumors. And so now we can say we have a medication that is also studied outside of everolimus. So thank you for highlighting that. Chandrikha, what about you?
Lisa stole the thunder with the cabbage and explaining it so beautifully. I think definitely everybody's excited and hoping and waiting for the approval of the drug. I think it's submitted to the FDA and looking at the review. But I think in reality, the data came about, the data comes about much earlier. So I'm sure, Menna, you too, like we have started using the drug already in patients that are eligible or appropriate. In terms of what's exciting, I would probably put it into big buckets of, there are trials that are looking at new drugs. New drugs, or like cabozantinib is technically an old drug with a new indication for this cancer. But like adding to the toolbox, definitely. And then there are also trials that are going on, more pragmatic in design, trying to look at, hey, what do we do with existing and how do we do it better? Does that make a difference? Like, the sequence of treatment, as we call it. And then there are also some trials looking at the practical questions that patients ask, about especially the octreotide. I got PRRT. One center will continue post PRRT and one center will not continue. Some will be on it indefinitely. And the truth is, again, as long as they don't have a functional tumor that makes hormones and symptoms, I don't think we have a good answer scientifically by research or trial to say this is fine, that's fine. So as we're adding options, which is very, very important, which is very exciting, I think it's also important to figure out these nuances of treatment, which we may be able to and may not be able to. And ultimately, it's a patient-physician discussion. But I think, so when I look at trials, I look at those two buckets, like, new trials, new drugs, new indications, and then also existing drugs or existing things, but more pragmatic, practical, day-to-day questions that are very important that we need to also try to answer if possible. So, there's always this excitement about the new, when we talk about new things, the new theranostics or the new PRRT, the alphas and other things. I don't know the patients that are tuning in today, how much they know and what they are, because, everybody, I think when they have started this neuroendocrine journey, at some point here's the word PRRT or radioactive therapy or Lutathera, whatever you call it, which is the radioactive element approved for therapy since 2018. And then we're already moving on to the next generation, so as to speak, of these compounds. So that's probably the other big area of excitement. There are ongoing clinical trials with specifically in the US, two elements. Dr. Haider's site, Moffitt, is one of the sites leading one of the trials with lead, and the other one is actinium, which is open at multiple sites across the country at different settings. There are some that have been looking at patients for PRRT after they have received lutetium, and some that are like, hey, you were diagnosed, let's do it right up front, right? So again, this is going to help add treatment options and also hopefully maybe help with the sequence of treatment on when to treat and who to treat with these drugs up front. A word of caution for mostly patients, ideally as much as possible when you're doing these type of therapies and treatments to get on a trial or kind of a more scientific, rigorous protocol where you have an opportunity for us to capture the data, but not just that, but like kind of doing it in a very vetted way is a better way to do this, right? If we start doing everything as a one-off compassionate use, you will never actually answer any question. And you could also end up with toxicities that you didn't account for and never know those things and warn the next patient or things. So thank you to all the patients, patient advocates, caregivers, everybody who helped make those trials successful a million times again and again. If not, there's no drug, no approval, nothing in this cancer.
Yes, thank you for saying that. Lisa, go ahead.
That was really a wonderful recap of what is going on. And I just want to also kind of highlight, even when we get excited about, oh, there's going to be a new tool or a new drug coming out, there has not been a magic bullet invented or one we know about. So while we may say, oh yeah, this is going to be approved or there's these trials, we have yet to find a magic bullet. There is not a magic bullet. These are all tools in the toolbox. And as Dr. Chandrikha said so well, that there are new drugs in development and we're still learning about existing drug. And so the exciting thing is there is a lot going on and a lot in development, but we need to know more about the order of how to give them, so sequencing, and the nuances, because there is no like exact algorithm or pattern. And that's what everyone, I know patients and caregivers all want that, but we don't know those things. So, it takes a lot of patience and communication with your provider and really understanding this. I also kind of want to back up to like explaining, because some people are new to PRT. So can I just kind of
Yes,
explain? There were a lot of terms there. So and I was thinking about this because I get these emails all the time, like my doctor recommended alpha and the alpha trial. And I said, which alpha trial? So there's a lot of terms. So there's PRT, you'll hear it to also maybe mention radioligand therapy. And if I could just say, like, remember back in the day, we used to use phones. So like there's a big bucket. PRT is like the big bucket saying phone, like a type of thing. And then there's types of like within that, are you using a landline or a mobile? So there's like buckets within that. So there's like the tried and true, beta or Lutathera PRT that's already FDA approved. And then there's the ones in trial. So back when mobile phones were being invented, the alpha is the one being invented, whereas the landline is the one that we already use. And within the mobile phones, like, do you use an iPhone or an Android? So again, within alpha, there are multiple, all in trials right now, all in development. So back when, people are older like me, back when iPhones came out, like, or mobile phones, like what kind of mobile phone? There's a lot that are being tested and, and they get better with time. So really understanding that these are all different terms in this whole big bucket. And I know that there's a lot of confusion and that's okay. We'll just keep like redefining it, but there's a lot going on even within alpha, that there's 3 different trials and probably soon to be more.
Thank you. That was a very, very nice example. I might use that myself. So thank you for sharing. So I think
one thing I'll convey though with that analogy, which just came to my mind since Lisa was saying that, right? People will say, well, the mobile plan is so much better than the landline, right? Which could imply that, which we don't know in this case. So just a caveat to that. I think we are, again, learning about these, right? Because they have their distinct advantages This has their distinct advantages. When we put them together, if one wins the battle, we don't know that also, which is again the trial that we may be doing in the future in this cancer. So
Yeah. Maybe back
Yes.
to like back it up like 10 plus 15 years when we didn't know all this.
No.
But yeah, imperfect metaphor, but really understanding that there's different buckets and they're not all equal.
I think the pace with Lisa alluded to in terms of the progress being made, that's something that's definitely important to mention to the patients and to tell them, like, don't lose hope. There's so much going on because, you know, drug approvals in general have accelerated compared to what it used to be historically for all cancers. From the time what we call bench to practice, right? From the pig, you know, like the pigs to monkeys to the humans. So it takes a long time, so years, but the amount of drugs, the number of studies going on in neuroendocrine tumors specifically have definitely, I don't know if there's a way to quantify, but doubled and tripled maybe in the past 10 years. And then the third thing I would want to say is one thing we have to make a conscious effort as a scientific community is, and this is specifically for low grade, but we'll also talk about high grade or what we call the poorly differentiated neuroendocrine carcinomas or small cell. So in the low grade, if you broadly look at the drug options, one is this radioligand therapy, which is the radioactive element still hinging upon something called the octreotide receptors. This is the mole we found on top of these cancers. We've been whacking this mole for a long time in different ways. Maybe it's time to also look for another mole, right? So that's one area we have to move forward as a scientific community. The other big mole is this pathway called mTOR pathway, which is a drug called everolimus. We continue to milk out from that. And then another one that is called the blood vessel feeding pathway. So these are primarily the three big pathways that we have developed drugs and continue to develop drugs in one way or the other. But that's not where we should stop. We should look beyond these three and to add to our toolbox. I think that if I have to ask for a wish list, that would be the big area as well, because you got to do this parallelly. You don't have time. You got to keep doing this parallelly. And the same way in high-grade neuroendocrine carcinomas, which is a very different type of cancer, chemo, and maybe in some patients, immunotherapy, these are the two big buckets we have and probably still have. But in the recent times, there are these exciting proteins that we have discovered expressed on these high-grade cancers like DLL3, like a specific protein. There are some drugs that are targeting that, or some in approved and some in ongoing clinical trials. Another one called SEZ6. I'm going to rattle out some scientific names, not expecting the patient to remember, but just to basically say, hey, there is hope. There's a lot of work being done. And, I think there's also work being done beyond the octreotide receptors also, which I'm hoping will also add to more options.
And continue to be quite personalized and specific to the tumor cell. So, when I think about chemotherapy, it's less specific to the tumor expression and target, if you will. And I think lower grade neuroendocrine tumor is a very good example about targeted therapies and targeting receptors. And I think broadening those targets would really increase our toolbox. I would like to share something that that I really want to highlight, and it is about higher grade, so neuroendocrine carcinoma, which has been slower to move and slower to expand. We've been using the same chemotherapy for about 30 years as our first starting point. And there is a lot of movement in after chemotherapy, the use of immune therapies or targeted therapies looking at this protein DLL3, which has already found effect in other cancers, and we have clinical trials looking at that. But there are, in the first treatment, clinical trials looking at different chemotherapies, being more specific about where did the cancer start. So if it's starting in the colon or small bowel versus breast or bladder, for example. And also combination of chemotherapy with immune therapy right at the start of treatment. And I'm really looking forward to upcoming updates about already ongoing trials that we are offering at throughout our cancer centers, and some of these are international trials and will be shared with us and can impact our practice here. So really a big hopeful forward advance for neuroendocrine carcinoma. I would like to move on to another question, and I think we can come back to our question from our patient. just to make sure that we have ample time at the end for a group discussion. Lisa, we talked about, and you pointed out, there's a lot of studies for the future direction, and we just focused on what might be impactful in the upcoming year. What did you see that you're really looking forward to? It's in the beginning of the research or topic that you're looking forward to that expanding for our future direction.
Yeah, well, we talked a lot about alpha, and I think that that is really exciting. And that, okay, we mentioned 10 years, right? Dr. Chandrasekharan just said a lot has happened in 10 years. My husband was diagnosed 10 years ago. We just passed his 10-year anniversary. And in fact, yesterday was his 10-year anniversary of his surgery. There were not that many options. Lanreotide was just FDA approved. Lutathera was not FDA approved, right? There's not that many options. And yes, things are evolving rapidly. And there are some things in development. So alpha PRT is being developed, and there were a couple abstracts, a couple talks about the ones in development. And again, we need to take this step by step. So just because there's a presentation about it or some data doesn't mean it's ready for prime time. It's going to be in clinical trials for a while, as Dr. Chandrasekharan said, and feel free to reach out and learn about those trials. But there's not just one, there's not just two, there's 3 trials, and they were all talked about in the symposium. 3 alpha trials. Showing that they're safe, showing a little bit more about what's going on with them. And that is really exciting on the side of treating tumors and with that treating symptoms, but also in treating symptoms, the paltusotine trial, right? The one that treats carcinoid syndrome, and the phase 2 trial was talked about. Dr. Man Chohan talked about the results of that and showing that it is helpful. And when we talk about symptoms, that is really something that affects people's quality of life and can really be the difference between being able to leave your house or not. And so having a new drug that is in development, so it's not yet ready, but maybe hopefully we'll move to the next phase of study this year so we can move towards it being more ready for prime time. I thought those were 2 really interesting things. And I know, for high grade too, that whole bucket of immunotherapy was talked about a little bit. And there's the DLL3, talk about the CAR T. There's a lot of things in development that are really interesting and exciting.
Wonderful. I agree. I think the PRT expansion is just, it just shows how we can advance from something that took a long time to come about in terms of Lutathera and now just growing. Chandrikha, what about you? Anything catch your eye that you're excited to see for the future? You could expand upon your previous comment.
I think one comment I would make, just because this is more geared towards patients here, is how do you seek and how do you know about this from a patient perspective? I think it's important. Here are all the people that, you take care of patients with NAT. Lisa is very involved in that world and goes to this symposium. But what about the patient? How do I know? How do I do this? How do I seek it? And that's probably where the advantage to seeing a NAT specialist comes. And, again, unlike another cancer, this cancer tends to, when the trials are there, unfortunately, also in other cancers, I should say, the trials are kind of closeted to some institutions and some places geographically. And so there's a lot of disparities in that issue. But, and not every patient, even if there's a trial or anything, that can actually go and be able to get it, right? But from a patient perspective, it's a question that's very reasonable to ask at every point in your journey and try to get an answer. Is there a trial for me when I'm diagnosed? Is there a trial when there's a growth I can participate in? It doesn't mean you have to, but that's the way. If we don't volunteer that information, it's perfectly okay for you to ask that question. If it's a no, it's a no. If it's a no here, like if you're seeing a doctor in one place and they say, oh no, there's no trial, it's okay to prod a little bit more and ask, hey, is this a no here? Is it a no everywhere, right? Because the trials are not open in all the places. And trials are not the solution to everything and not necessarily for that patient, that situation. But as a patient, one way to learn and is to want to advocate for themselves is to actually just ask the question, is there a trial? and try to get an answer. Outside of these webinars and other content that's put out is another good way to learn about them. In addition, there's your oncologist or your NET specialist, whoever, whatever you're seeing. Both of them are probably also your more scientific guidance to if there's a trial available, what does it entail and what it means. So I think that's just important because we keep talking about trials and all these developments, but like, how do we get this? How does it actually work, right? How do we patients get to that? It's important. And I think there's going to be also trials looking at like early diagnosis and things like that, hopefully in the future, but like that's something to look at. To expand, I think between Lisa and I and you, I think we covered a lot of the big areas, and Lisa definitely covered the symptom management thing, right? I do think the lung neuroendocrine tumors, or what we call unknown, is probably deserving of more attention. And the why is it different? I think there are differences, we know them, and what are the differences? We don't know them exactly, compared to like a small bowel or pancreatic. I think to learn more about I guess the genetic makeup or the DNA of the tumor, for example, like in a simple way, or the proteins that go along in this tumor proliferation. I think they are different, likely in different tumor origin sites. And we probably have not put a lot of effort and energy or money yet into the lung net group, still because it's not as common as the others, but it's still like a growing incidence. So I think that's one area I'm hoping we will steer our future. I think there are, we have to start again from the basic science, taking cells, letting them grow in petri dish sometimes if they grow well, and go from there. And the other, again, I'm trying to think of everything. I think we tried the DLL, we talked about alpha, we talked about cabozantinib, we talked about palsitosin, the oral drug. So I think I'm blanking on anything else that's that I would like to cover. So
Well,
I
I
think you
think
covered the whole gamut of trials, I feel.
we did. Speaking of, well, we have a few more minutes, and we do have a question that I think we can share our opinion. There's a question about anti-parasite treatments on helping neuroendocrine tumors, and I think that there is access to experience and personal experience shared in one's healthcare journey. But I think our discussion today highlights our approach in how to gain the best benefit, which is really looking at high quality. Does this really work, or is it a one-off? Because if we take on treatments that have their own side effects, and every medication does, just based on this looks like it might work, or it worked for a small group, many times the reason we can't advance is because when we really look at treatments, we either find that it doesn't pan out the way we would have expected in terms of benefit or safety, or it doesn't expand into a larger population where it really serves in treatment. And in my view, I always support my patients in seeking different treatments, and I don't oppose it in conjunction with my treatments, as long as we are transparent about it and looking for any side effects that might come about. But if I were to recommend a treatment, I do base it on something that's studied, where I can inform the best I can about how it works, what are we going to gain from it, and what kind of risks are we taking with its use. I'd love to hear both of your opinions about that.
I think there was some kind of an article in one news outlet or some news outlet about this ivermectin and cancer, which is because I hate to say I've seen a resurgence of this ivermectin question. I wish, it would be as simple as that. There's absolutely no data for not just NET, but any cancer. There are definitely some studies being done. So again, like Lisa said, there are studies that doesn't conclude, you can't conclude that it was working until you do a study. And people may argue, well, there are a lot of people not doing studies on these drugs that have been generic and around for a long time, which I agree. These are unfortunately the pitfalls of, the big pharma, whatever. But but having said that, It's not as simple as that. And unfortunately, there's no, at this moment, existing literature to support this. And here's a word of caution. We've seen more than one patient or share where they've been taking ivermectin without telling us or letting us know, and on another drug or something, and the liver numbers went up. So these drugs also have consequences, bind themselves and in interaction with the drugs we know to give for these tumors. So I would not recommend it at any circumstance. Maybe if there's a large trial, if you prove it, I think all of us would be happy to. And I will also say this, I'm originally from India, where we've given a ton of ivermectin for parasitic diseases. India should not have cancer because we literally probably sprayed in the water. Or some of the diseases that we do, or mebendazole, which is another question, fenbendazole. These are like, I think I've literally given it to every child there I've seen. So I think it's not that straightforward, and preferably
That's a very
avoided.
good, yeah, that's a good point that we can, you can consider it is used in higher numbers in places where there are a need to treat parasitic infections, and yet we are still seeing cancers come about. Thank you for bringing that point to our attention.
I
Lisa,
think
what is your,
I was going to say this is the question with Bob Marley and marijuana. Like patients always say, hey, if marijuana could cure cancer, Bob Marley would not have died of cancer, right? So
Lisa, what's your
Yeah.
approach, or what's the feedback
Yeah.
that you have for this too?
I understand as a caregiver, right? I mean, I understand what it's like to be looking for a magic bullet and to also feel desperate, right? We're all looking, and our loved ones are looking for something that'll work, that one magical thing. And it is not yet out there. We all wish that it was, and if it was, we'd all be taking it. And I would just really warn, because there's a difference between research on Google and in Facebook groups and real scientific research that goes through a rigorous process and rigorous study design and the way things are studied in a scientific way. It is always best to go with something that's already studied, that there's a lot of information, data information, like scientific information about, not just Joe tried it here, John tried it here, Sue tried, not just one-off people, but really a lot of information, data. It's safer because there's more known about that. Go with those things that you know a lot more about versus a new hyped, shiny thing that we don't know a lot about. I mean, we've seen this happen with outside of the cancer world, like say, toys, like cars or whatever. Some things come and go, and it's like the biggest hype for a while, and then it fades. And it's like, oh, remember when that car was in fashion or whatever. Those are trends, and it doesn't necessarily help us. And that's, not something that we're ingesting in or taking, or a loved one that could actually do harm. So the first rule is for providers is do no harm. We want to make sure these things don't harm us. And there's a lot of some of these things do harm, and some we just don't know if it'll harm yet. And then later on we find out, and we don't want to get to that point. So even before doing good, we want to make sure it does no harm. And so there's some of these treatments that we just don't have enough treatment yet, information, and we wish we did. There's a lot of exciting things and buzz around things. And so it takes some time. So yeah, go first with the things that are approved and known about, and your doctors know about, and they have experience with, before the experimental ones.
And I think part of this is also a question that I have, what can I offer that you can control? And a question that I receive, well, what can I do on my end? You're telling me we can prescribe this medication, so what else can I do for myself? And there are certainly very well understood benefits of habits that we can control, like activity. And it's not something grand at a gym. It's really data for walking, and diet, which is very important, especially in neuroendocrine tumor oncology, because we're doing surgeries that affect how you eat, and it can cause symptoms in how you absorb your nutrition. So those are a big focus that are real and we know can be of benefit, and certainly something that you can collaborate with your physician or provider about.
I was at one of the scientific meetings last weekend. I missed you both, but there was an hour and a half session on integrative oncology, exactly what you're
Right.
mentioning. The exercise, acupuncture,
Mhm.
mindfulness, other things that you can do to help with symptoms. And there is data around this. And I know, as supporting my husband for the last 10 years, we are looking for those things we can control and to reduce side effects and improve quality of life. So there are things that you can do.
Mhm. And so we know better about the others as well. I can. I think we have a couple of more minutes, and we have two questions. I think we have time for one of them, and it's about functional tumors. How do we know? How do we know what to test for? And it is very important to recognize symptoms that can hint at an undiagnosed neuroendocrine tumor and find it, or when it's known that there's a neuroendocrine tumor and looking for symptoms so we can understand how to follow and treat you. And in my approach, I kind of cater or tailor the testing based on the symptoms. So, for example, if my patient has been to the emergency room with really low blood sugars and there's a tumor on the pancreas, I will evaluate that for insulin. Is it making insulin? It helps us understand if it is functional, that we should be looking at removing it or how to approach your care. And so you can really understand what tests are needed based on the symptoms that come about instead of doing all the tests that might not be applicable for you uniquely. Any last thoughts from either of you? It was really a pleasure, and you shared some information that has brought some things to my attention as well. I really thank you both for your time.
I would just add, there were a couple sessions that stood out, and they were actually in the non-treatment realm. One of them, I was part of the panel discussion called "Can We Talk?" and the challenges of communication across the board, whether provider-patient or provider-provider, and really just the importance and the value of communication, how important that is. And the other one was in the Great Debate panel, which I love that one anyways, because you're kind of nerding out on the argument of two sides, but that included a patient perspective. And I was talking to a resident actually last weekend at a conference, and she said that really stood out to her because it was a really human moment when the patient was saying, look, we're willing to take on the risks, and the doctor shouldn't feel bad if such and such happens or it's not a good outcome. And the doctor, one of the NET experts said, but we feel responsible, and that was a really human moment. These are things that we don't always talk about. We're in these medical and scientific meetings, and opening up those conversations to the relationships and communication, I thought that was really special. And also just outside of the meeting, so much magic happening with connections and collaboration and relationships. I mean, it's something that you can't quantify, but the buzz and the energy, we come back, even though it's exhausting, it's so busy, we come back energized, right? And all of this ends up benefiting all of our community, the patients and the caregivers.
Thank you for saying that, Lisa. I think that's what keeps us going as probably physicians, this connection, right? If you don't find this human connection in medicine, it becomes very hard to practice. I think especially oncology. And so it's hard to motivate yourself sometimes to do oncology unless you have this connection.
And I just want to say there's so many dedicated people, all of you, Dr. Haider, Dr. Chandrasekharan, Tama. If it weren't for all these people, my husband would not be alive today, right? I mean, directly or indirectly, they're all working on our behalf. This is why and how we're here today and how we're going to keep kicking the bucket down so we can buy more and more time and be able not just live longer, but hopefully thrive. That's the important thing, to live well. So there are a lot of people fighting on our behalf. I know sometimes you feel alone and isolated, but you're not. There's a lot of people working super hard on your behalf.
Thank you so much. I don't think I can end on a better note that really captures what NANETS was about this year. I want to highlight again your podcast that will be coming up, looking at the 10 big concepts to share. So we will have that on our website and social media. Please look for that. Thank you so much to our attendees. I hope you found this information helpful and kind of learned about the NANETS community. And join us next month for our next webinar. Thank you both for your time.